So next what we're going to go into, and let me change that camera before I just... Okay. Next what we're going to go into is treatments of the knee. So mobilizations of the patella. Something, very often we'll do with many patients, from post-surgical to just general patients that we feel stiff tightness and all that good stuff. So of course we all know the glides. You can go medial, lateral, you can go superior, and you can go inferior in that sense, and just doing a combination of all of those things. Oftentimes what I'll do is I want to pin this down a little bit and then mobilize with this hand. I'll often be sitting because I want that into the plane, because oftentimes if you're coming down, you're just having a lot of that compression. So we all know that very well, but there's also some other variations we can do. So, if I want to go into flexion, what I always can do is have a little bit of bend. I can come in, kind of grasp and do a mobilization with movement. So I can move it for them just like this, or I can go ahead and bend your knee for me as far as you can. Go ahead and relax, just like that. So, or if we have problems with extension, I can always come down here and have them extend out, just gliding how the patella is supposed to do. Now, just beyond that, you can actually do a variation. So say that I don't think they're really getting it as they go up. Maybe they need to go a little bit medial and inferior, etc. I can kind of apply medial and inferior. Go ahead and bend your knee for me. Gliding just like that, back and forth. So, we know how the patella is supposed to go up and down, but it necessarily doesn't mean that we have to stick to that way. Mobilization simply is, does it improve? And if it does it continue? Is it the painless, instant, long-lasting effects? Some issues, things you can do as well is a little bit of mobilization with movements, just like we do with the elbow. I can come in here. So say you have a very knocked knee patient. Come in here and you can kind of unload a little bit. So on side, go ahead and bend your knee for me. Coming up and then coming back down. See if that works, and then switching. Go ahead and come on up and then come back down just like that. Again, try to do the best you can for the body type, etc. But at the end of the day, it simply is, does this change things? It's a symptom modification. If it does, keep rolling with it. Quads, pin and stretch. There's a couple of ways you can do it. Of course, you can get off the side of the bed, holding down, going down. Something that I really like to do, especially if we've, you have those patients that kind of get gummed up at the top end here. You can always come down at an inferior glide to the patella, and then come in with this hand and just work into that. So I've got the patella really pinned down here, and then I'm going into the soft tissue and working it that way. And you can kind of do both hands at the same time. You can pin down and then go, but it's actually a little bit of different kind of pin and stretch that we can do. Alright, so our normal physiological knee extensions, what you can do coming up. So we know these very well, our 2s and 3s. So say you have a patient that's kind of restricted in this range, going into that large amplitude, working at 50%. So let's say for her, she doesn't really have it, but if she has some stiffness working in, and also to her 4s, something to, we all know this very well, we all do it. Something to keep in mind though is your natural alignment is going to affect this. So if you're used to working with knees, you come in here and you start coming down and you're moving, but notice where my hand is. It's not here. If I come here, I'm going to affect it. Or more importantly, a lot of times that internal rotation is not occurring. I can go internally and do that. So if you're having a patient that you're at that end range flexion and you're not getting, it's too uncomfortable, etc., look at your elbow, see if maybe you can play with the rotation a little bit and start coming in, and you might actually be getting more ranges and actually feel very comfortable with that, you and your patient. Knee extension is the same way. Oftentimes I'll come down and here work like that, or what I'll do is come in with this hand here, and I'll actually bring the ankle up and mobilize down right there. You can always, again, work into your quadrants into that. There is a distal tib fib manip that you can do. Go ahead and scoot off this way for me a little bit. This one is not necessarily my favorite, to be honest, but you can always have their leg hanging down so that I have between my legs, I'd want the bed up a little bit higher. You want a little bit of flexion. Make sure that they're not falling off the bed. But bring them down to about right in here and then manip down just like that. So, PA, proximal tib fib manip. I'm going to show 2 ways to do it, and then I'm going to show my variation that I've kind of have incorporated in the clinic. I'm owning it. I've created it, so hopefully people don't just dog it and don't like it because I created that. Hopefully I created it. I probably stole it from somebody, but I'm going to claim it. So the first one, if you're going to do a PA, superior tib fib manip, 2 ways written up in the literature. First, coming in here with your hand, pronating a little bit, and going down to that end range right in there. Perfect. So, I've got it here. You play with it, find that kind of, almost like that twig about to break. Any pain right there? Good. Go right there, and then just down like that. That is one way. Oftentimes, you have to have a patient with pure knee flexion to get that. That can be really hard because a lot of patients that need this, huge population, is your TKAs, not TKAs, TK, well, it really would be with your TKAs, for your total knee replacements. They can't get full flexion, so you can't do it. There's 2 ways to do it. First is go ahead and roll on this side for me. One way it's written up well into the literature is just doing a side-lying manip. You can also do this one in a chair. There's a couple different ways. I'll mobilize in this position a lot, where I've got down here pegged, so I can stay in here, just kind of working like this, and then I want to, and I've got it pegged down, and I feel down here having that grass helps out a lot, but just kind of going to that end range and manipping like that. The other way, I like the flexion one a lot if they have the thing, but what you can do is go ahead and lay on your back for me and lay at an angle a little bit. And grab a bolster, something like this in the clinic. Go ahead and lift your legs up. So this is the kind I've created for my patients, is you want the bolster and you want to be able to get their leg off the side. So right now I'm not hitting the table. I've got her pinned. So go here, go down till you find that end range, and go down just like that. So the only problem with that, you have a little bit larger amplitude because the bolster is a little soft, but if you have a patient that really needs this to go, it can really, really help out in that sense. One that we didn't show, of course, is the hamstrings pin and stretch, where we're just going down, holding on those hamstrings, going in and out of that flexion extension. But what I wanted to do before we went into, a few more things is kind of show some different variations of things I'll do with patients. Go ahead and sit off the edge with me. So I don't often do this in this clinic because I don't have a high-low bed, but I used to only really treat knees in sitting unless they were post-surgical. So, as you see, not the best height, but what you can do is if you have a high-low bed, you can bring them up, pin their leg down, and drop down, and add a little bit of distraction, especially for your arthritic knees. This could be heavenly. Hard if you don't have the adductor strength, you can always tie a loop around their ankle and step down on it like a gas pedal wrapped around their ankle, and they'll pull it down just like that, which can actually be pretty comfortable as well, especially if you're going to be doing this for a while. So come down here, pin it down, and then I can work into a lot of my APs, PAs. Most importantly, I can also work into my rotation, so I can really get a good feel into here if they're internally rotating, if they're externally rotating. I could just simply distract in here, or I can distract and mobilize, especially if I feel like that knee needs to get moving, but we necessarily can't do it because it's just too painful. So I can distract, mobilize, and can feel pretty good. And also I can do a lot of my mobilizations with movements in this category as well.